Hi, Tom. So this is Tom Carter,
Okay.
and my name's Sarah Mitchell. I'm one of the orthopedic consultants in Fife. I'm going to do a viva about knee dislocation, and we'll go through a little bit of clinical viva session on that. So, Tom, there's a 35-year-old gentleman who's brought into the emergency department who has been playing rugby and he's had a very nasty twisting injury to his knee. Just tell me how you would go about assessing him.
So first and foremost, if I'm concerned about the high injury nature of this injury, I would assess the patient according to ATLS protocol. But if I'm confident that this is an isolated injury to his knee, can I
Yeah, so his
assume that?
ABCs are all fine, and he's complaining of severe pain in his right leg.
Okay, so first of all, I want to make sure that the patient is adequately analgesied. So providing him with some opiate medication if that is required. I'm then going to take a focused examination, asking about the mechanism of the injury, any relevant past medical history, any surgical history, any allergies. Really, I'm going to focus most of my time on a focused examination of the lower limb. And in particular, I'm looking for any obvious clinical deformity of the limb, especially around the knee. If he has any associated fractures, so performing a full circumferential examination, looking for the front, sides, and the back. I'm going to probably not be able to do much in the way of movement if it's had a significant injury. It's probably going to be a lot of pain, but the main next step in my examination is going to be neurovascular examination.
Okay.
So checking his sorry.
So he complains of a lot of pain centered around his knee. He has extreme pain in his knee. He said his knee went in a funny direction and made a loud clunking noise. But currently, when you look at it, it looks a normal alignment.
Okay, so just listening to the mechanism, I'd be suspicious for a knee dislocation, although not all knee dislocations present with ongoing deformity at the time of presentation. That would be in the back of my mind. Was that a spontaneous dislocation? So I'd have a real good feel around the back and the popliteal fossa, because there may be an expanding hematoma, which I can't see from the front. And I'm really concerned or thinking about any potential neurovascular injuries. That's where my neurovascular examination comes in particular, feeling the distal pedal pulses. I would also assess for mainly sensory distribution of the distal nerve supply, as he might not be able to comply with motor examination, but I would try and test this too.
Okay, so he's able to wiggle his foot, but what specifically would you examine there?
So I would want to examine the distributions of the common peroneal nerve, so particular sensation along the lateral border of, so the lateral aspect of the foot, which would be the superficial peroneal nerve, and I'd also examine the deep peroneal nerve distribution in the first web space.
Okay, so that's not, he's not able to feel any sensation in those areas.
Okay, so in this situation, he may have an associated common peroneal nerve injury, which is the highest associated nerve injury in a dislocation of the knee.
What motor function might you test? I mean, he is able to wiggle his toes and things, so most of the time they can do something slightly painful.
So I test his great toe for extension of the great toe, which would be deep peroneal nerve motor distribution.
That's absent as well. You can't do that.
Okay. I could also test a tibial nerve function as well, although tibial nerve isn't as commonly injured in a knee dislocation. But in that situation, I would test sensation along the border of, along the plantar aspect of the foot, and I could ask him to plantar flex the ankle, which is tibial nerve motor.
Okay, so that's fine. That's normal.
Okay, good. And then I would be checking his pulses as well. Does he have normal pulses and dorsalis pedis and posterior tibial pulses?
No, that you can't really feel them properly.
Okay. So I would be at this point, if I was concerned about poor pulses, maybe thinking about having the opinion of a vascular or plastic surgeon. But really, before I do all that, I'd want to get check his ankle brachial pressure index using a handheld Doppler and a sphygmometer. And I'd also like at this point to get some fairly urgent imaging, including an AP and lateral radiograph, to see if there's any ongoing dislocation of the knee joint.
Okay. What sort of numbers are you looking for with your ABPI?
I'd like a ABPI of greater than 0.9 to reassure me.
Okay, so it's less than that, actually.
Fine. Okay. So I'm concerned about an arterial injury here to the limb distal of the knee dislocation. So I would be, again, relaying this information back to my vascular colleagues, and I would be wanting to investigate this further, and the probable line of investigation would be a CT angiogram of the lower limb.
Okay, what else might be done other than a CT angiogram?
And
No,
just
that's fine.
no, that would be my first line. I guess if the patient's going to theatre and there isn't any facilities to support CT angio, then an on-table angiogram might be an alternative.
Yeah. What would you plan for, and what would you be arranging if they're planning to take this patient to theatre?
So at this point, I am the on-call consultant. Therefore, I'd be speaking with my theatre team, my anaesthetics team, to get things set up in a CPOD emergency theatre environment. I'd have the help of my vascular or plastic surgical colleagues. I'd be prepared to perform some temporary stabilization of the knee joints. This would facilitate the vascular surgeons to perform a repair or a graft of some description. But in the process of doing that, there would need to be a degree of stability within this knee dislocation. So I'd be thinking about putting a temporary spanning external fixator on the knee.
Okay, so what are you going to ask your theatre staff for? It's getting into the evening and your usual orthopaedic team have gone home. What are you going to ask for specifically? Because they're not actually very sure about what they need.
Yeah, okay. So I'm going to be, for spanning external fixator, in my unit, I'm familiar with using a Hoffman X-Fix. So I would use a Hoffman set, and I would need the assistance of radiographers, intraoperative fluoroscopy. That's the equipment I would ask for. I double check the X-Fix myself in advance to make sure that I've got the appropriate size pins, number of bars, and connecting pieces for that X-Fix.
Okay.
Need fairly long bars to be able to span the knee joints as well.
Okay, good. Fantastic. So that's over 7 minutes now. So that's a good good full answer you've given there for that case. What you can sometimes get is maybe the examiner can expand on that and maybe ask what you think that may happen from a vascular point of view. Obviously, you're not expected to be a vascular surgeon, but you are in this situation prepared, supposed to know roughly what they might do on tables, because you then may be the surgeon, and then depending on your specialty, subspecialty, you might be going on to then do further surgery in a few more days once the stabilization has been done and the repair has been done. So yeah, this patient went on to have an on-table arteriogram, which showed that there was a cut off at one of the vessels, and they had a repair done. So I mean, you answered that all very well. You're very good at the start. You just start with your ATLS. Be slightly wary of just presuming that it's okay. Just do it as if you were there and you were dealing with that patient. If there's anything that the examiner wants you to stop at, then they'll mention that. But just go through the process and say, look, I would do an ATLS, ABC, and if they're happy that you're going through ABC and you're doing fine, they say, okay, leave that, carry on with the next bit. Also, you don't in an exam get warning about what kind of case they've got, but then they will lead you down the right way to where you're supposed to focus your examination on. It was a very good description of your examination and all the different areas that you would examine, especially the main neurovascular areas and the pulses, sensation, motor function. The one thing you didn't mention was looking at the color of the limb. This patient had a white leg, so it would have been even more obvious, straight away.
Critical ischemia.
Critical ischemia, and finding out the timing as well. So you want to know roughly what time the accident happened or the event happened, and whether the patient noted any change in their sensation afterwards, or whether it was immediate, where they felt that there was some. They might not be able to tell you because they've got a lot of distracting pain, but they may be able to give that information. So it's useful to just know for timing, especially if you're relaying that to your vascular colleagues, what extra information might be helpful, because that might influence how quickly you want to get that patient to theatre. That was a really good answer about the kit that you would need. Sometimes you need to go into even slightly more detail.
Yeah.
You need to ask to make sure you've got power tools, as well as
Okay.
your extra large normal set. So you've got to, usually they put these pins on open. You can put them in percutaneous very quickly, but if you've got the time, then you're better to do a bit of a cut down onto the bone and see that directly pre-drill. Although a lot of pins these days are drilling and tapping themselves, but
Okay.
you still, to be able to get good hold with the pins, sometimes you are still better to pre-drill, so then you're not cutting out your thread and you get through the second cortex.
Right. Okay.
Pins.
And what size pins are they normally? Are they 5 mil or
You can get
6
different
mil?
sizes, but usually about 5.5 or 6.5
Okay.
pins, and they're half pins.
Okay.
But yeah, make sure that you go down with the staff to check the kit. That's what you said you would do. So that's really good, because most pins are sterile packed separately. So you need to know how many pins you're going to need. You might need to set a few extra pins if things go wrong, and making sure you've got all the kit to tighten it up, which is what you said you would use. A lot of people do use Hoffman, and it's important to make sure that you say that you're using the one that you're familiar with. And usually you'd need to put the stabilization on before the vascular guys do their repair, because they want the stable knee, which is what you said you would do. So it's also
I have, when I was reading. So when I was reading around this, some people said that the critical thing here is to perform the vascular repair, and then the stabilization goes after. But that doesn't really make sense to me. I always thought like you need skeletal stability and then you do a repair, don't you?
Well, it would require a discussion with the vascular surgeons, but majority of the time you would want to make sure that the stabilization is there already, so that then if you're putting on pins and an X-fix, you're not going to disrupt their repair. And you'd also want to discuss with the surgeons when they'd be happy for an actual more formal stabilization of the knee to be done. Majority of the time they're happy with a few days, because you want to be doing a repair of a multi-ligament dislocation of a knee within a couple of weeks to make it the easiest surgery to perform, as it starts scarring, and your perineal nerve is going to be more scarred around. Often the perineal nerve can improve on its own, but it may be one other part of the knee that you'd want to check on afterwards. You'd want to arrange an MRI scan of the knee. So you may be able to get MRI friendly X-fix kit, which means that you can get an MRI scan whilst you're actually got the frame on, and that'll help you to know what ligament injuries you've got in the knee directly, so that you can plan, so that whoever's doing the knee surgery afterwards can plan that more specifically, and also look at that then can look at the nerve. You may also get an ultrasound scan of the nerve to look at the continuity of the nerve that you think is injured. So that's extra things. So if you're getting to that sort of detail, then you're probably getting to a very good pass of that question. So you're getting to the much more detailed parts of that question.
The thing that I missed is with the vascular repair, we should be performing prophylactic fasciotomies as well.
So again, just with the timing, then you'd kind of covered so much. As the main thing with any viva question is, if you're talking and you're saying all valid points, then you're gaining points. So if you can keep talking as much as you can and then you run out of time, it's not that unless it's something that's really important, valid, if you've got going down the right track, then you'll still be gaining a good mark for that if you're saying all valid pieces of information. You never have all the time to say every single bit of information that you would want to about some particular case. But if you're doing it in the right sequence, which is what you did, then that also is a good way that makes sure that you're getting all the information out that you should for the case. And it's quite hard as an examiner to try and keep things short as well anyway. So if you can try and keep talking about and then talking about information that you know, then that will be really helpful for yourself, for you getting the right points for your viva. Any particular things that you think that you maybe would have said?
I think the whole point about ATLS assessment, I think I probably just skipped over that too quickly and was like, I kind of assume this is an isolated injury, and I guess if they say yes, but it may well not have been, and you may have had a C-spine injury,
Yeah.
for example, and I just kind of rushed over that to get to the sort of juicy part of the case. But
Yeah, I mean, it's quite important to make sure that you do check for that, because although it's life before limb, you've got to make sure that you're not missing any other things that are also a very severe injury. With playing rugby, if you had rugby injury, you can have neck injuries, and you also want to be getting that sort of line of treatment getting started, as well as the knee treatment. So you've got to make sure you're not missing anything, and doing a sort of do a full survey of the patient, and then they might just hone you in on that one particular part to examine as part of the viva.
Okay.
That was really good. Well done.
Cool. Thanks.